there's two kinds. Or vice versa, or sometimes I'll ask. Anyway, it doesn't include taking over patients from retired physicians or patients who move away, or they're moving here from Ontario, or the physician has moved. So these are the requested second opinions. That's what I'm looking at. And so is it reasonable, so by a show of hands, how many people think it's okay to ask for a second opinion? And how many people think that it shouldn't happen? Okay, yeah. And I think that if you look at the basic principles of ethics, and the principles we use are autonomy, so the patient can choose or refuse, then that's first. The second is act in the best interest of the patients, but autonomy is first. Act in the best interest is second. Do no harm, or in our case, in Barry's case, try to do no harm. Try. Justice and fairness. So what's fair? You know, in limited resources, what's fair? And then lastly, truth-telling, which is the basis of consent. So I think looking at this, I'm thinking it's okay, as long as it's fair, as long as no one else is suffering or missing out because someone's getting a second opinion. And my disclosure here is I didn't. This is what I used to write about it. So because it was limited, I would send this out to the family doctors. If I was getting a referral for fibromyalgia or osteoarthritis or something that I didn't actually need to see, I would send this out and provide some recommendations. Like for OA, I would say call Oasis or a good physiotherapy, exercise, weight loss are the basics of OA management. They don't need to see me for that. Fibromyalgia, there's guidelines I wrote. They don't need to see a rheumatologist to diagnose or begin treatment. And then another option is to call the race line. So this is what I used to say. And I said, you know what, my wait list is too long to see second opinions. Now that we have a bunch of new rheumatologists out there, my wait list is shortened, so I started to see them again. And you've seen my patients for second opinions too, I'm sure. And for that, I thank you. But I think it would be very difficult if there was no option. Say you're in a small town, or in certain countries there's rostered care. Basically, if you're a patient in this group, you can only see these doctors and you can't see anybody else. And I think that if you see my patient for a second opinion, and if the patient's agreeable, send me a copy so I can know whether I've missed something or there was a problem with communication. I think that's what I like. That's what I try to do when I see second opinions. Because you know what, if you're just on an island and there's just one doctor, it's kind of a bad situation. You guys are stuck with each other. And just a summary, when I do see them, I usually agree with the care and I invite the patient to return. If it's a patient-driven second opinion, often the patient declines to return to the previous doctor due to communication issues. And I'm going to talk more about that. And then Taylor says, this is what he says, you could make it a condition of giving the second opinion that you will not become the consultant of record. You could also make it clear to the referring MD that you will be copying the present attending rheumatologist. And often the initiating reason for requesting the second opinion is poor communication from patient to room or GP to room. And he says, Shojania, you have been a facilitator of poor communication. And to that, and I think he's got some points there, but then if we go back to the principles of ethics, regardless of all of this, if the patient really wants a second opinion and it's okay and it's fair, then I think it's still okay to do it. And then we request them of each other too. And for a nominal cost, the opinion can help confirm or refute a diagnosis. For unstable patients, you've got two people that are available. Esdale says, one specific time he strongly encouraged a second opinion is when the patient is going down the tubes and is reluctant to consider treatment that may make a difference, and then he provides an example. And he said, I don't ever mind a patient wanting a second opinion. They're dirt cheap. He says the cost of 3 days of anti-TNF therapy and are usually informative, and the patient's always happy they've had one. I think I would agree with that. And the most recent significant reason that GPs will request second opinions is they disagree with the care plan, or the patient's dissatisfied with the current provider, again, due to communication, availability, office staff perceptions and personality, and sometimes word of mouth. Like, oh, you should see Casson. You know, he's the guy to see. So, and then someone says, I want a second opinion from Casson. So here's an example. My first example, I did a second opinion on my own patient, pre-electronic medical record. So the chart was shredded. I diagnosed rheumatoid arthritis 10 years prior. Patient was on methotrexate for the past 6 years. Now sees me again. The new family doctor referred didn't have my old letter. I didn't have it. I didn't remember the patient. The patient comes in doing really well on methotrexate, 15 milligrams once weekly. Sporadic blood monitoring over a few times a year has been fine. In remission, normal sed rate, no erosions, rheumatoid factor negative, CCP negative. I don't know. So I'm thinking, I don't see anything going on. Maybe the patient had rheumatoid, maybe not. So what I did was I stopped the methotrexate. And I don't think he has rheumatoid arthritis currently, but now I have the benefit of hindsight. And Taylor correctly says it doesn't have to be an old patient. Sometimes you should take the time with a current patient to do a full reevaluation when that patient is not responding to your initial evaluation. I totally agree, especially in hospital. In hospital, it seems like the first time you see the patient, a full history and physical is done. 2 weeks later, things are not going so well. It's worthwhile to get another full history and physical, get them redo that, physical exam especially. And second opinions can be a business venture. So here's one that you can, it's a 24/7 support. You call this number, you can get a short written report, an extended written report, a full chart review. You could do written, phone, or video consultations. That's in US dollars. Johns Hopkins is #1 in rheumatology, apparently, and you could get second opinions here, too, and pay your bill on this site. This is an interesting one, diagnose.me. I think it's based in Germany, but you can get, you can select from the world's top. First of all, you could select the diagnosis or body part, then the top world specialists, upload your images, and get your independent report. I thought that was interesting. And of course, Mayo Clinic is also ranked #1. But if you look at the list here, cancer is #3. So I don't know if I've got cancer, I want to go there. But anyway, you can get your second opinions from the Mayo as well. So it's a business venture out there. So here's some of my most recent second opinions I'm going to go through. And I've changed the names, okay, to Game of Thrones characters just so to keep everything confidential. So Sansa has a 24-year-old with newly diagnosed lupus. So the family asked the GP to refer to me, and the GP agreed, so I got the referral. The previous rheumatologist had done a thorough and excellent job at the diagnosis and treatment. She had severe lupus, she had cytopenias, marked alopecia, she had mucosal ulcers, joint involvement, she had full house antibody profile, which means when we say full house, ANA, DNA, ENA, Smith is nice and specific for lupus, but not as sensitive. And I'm happy with RNP or any of the others to add, so 5. She had full house, and when I saw her, I thought she had new active urinary sediment, and she seemed a bit off to me, you know, quiet, but I just met her for the first time, and you know, later on I realized, once she got treated, I realized she probably had some CNS manifestations initially, very sort of flat at that point. But anyway, I agreed with the previous treatment. She was on azathioprine, high-dose prednisone, tapering prednisone. She was on hydroxychloroquine. But then they said, you know what, can you just continue seeing her and her parents, because they knew the previous rheumatologist in a social setting. Kaylor says, so why did they go in the first place? I don't know, Kaylor, but you know, sometimes you just have to let things go. You have to just carry on, and maybe, who knows what the real reason was, but I think that it's okay. It's all right. So that was one example. And, you know, we see lots of people like that. The disease is actually progressing while they're especially if you see the second opinion early on, the disease sometimes changes, and she developed brain and renal involvement. She's done very well on MMF, off prednisone now, back to university. So Tywin is a 65-year-old man with a GPA and a recent relapse. All right, and this is a tough one because he had previous renal involvement with his granulomatosis with polyangiitis, and he was treated with cyclophosphamide and high-dose steroids, which is perfectly reasonable. We usually step down to azathioprine, and he was at 1.5 milligrams per kilogram per day, which is also quite reasonable. But he had an upper airway and ocular relapse. They typically get scleritis. The current rheumatologist planned to give a partial steroid pulse, topical therapy, so drops and intranasal steroids, monitor by ophtho and ENT, and bumped up the azathioprine to 2.5 milligrams per kilogram per day. Perfectly reasonable. We have actually no data. We don't know what to do with a limited flare of Wegener's or GPA when they're on treatment. There's no studies, nothing we can work with. So this is a perfectly reasonable plan. And when I saw the patient, I agreed with the plan. However, I did refer the patient for an option. We are doing a study looking at abatacept for non-renal relapse of GPA. So I referred him for the study. The patient preferred to continue with me because he felt there was not enough communication with the previous rheumatologist. So that's fine. I referred him to the study. I don't actually know whether he got placebo or abatacept, but he resolved. But the symptoms resolved. And Kaler says, it's always going to seem that you're communicating better. You're aware you're given a second opinion, and of course, no matter how mistakenly they think you're a wonderful doctor. People tend to lie, and poor communication is always an easy plea. Ouch. And anyway, this is another, I'm going to come back to that. Cersei Lannister, she's a 40-year-old with spondyloarthritis coming to me with a second opinion, for a second opinion. If you've seen the show, you really don't want to have her as your patient, right? Yeah. Anyway, she has a diagnosis of spondyloarthritis based on enthesitis, the shoulders, chest, spinous processes, and iliac crest. And if you talk to your rheumatology colleagues, they're not going to like this very much because most of us have tenderness over those areas. It's a very common spot. My favorite area of enthesitis to diagnose isn't tender all the time. And you know what that part of the body is that it's really good to use? What part of the body? And rheumatologists, feel free to. Which is the best part to diagnose it? Most accurate. Achilles, yes. Achilles heel, the heel, because you know what? That should not hurt. That should not hurt. Everywhere else, you know, if you just press on your own, you're like, oh, I'm a little tender there, I'm a little tender there. So anyway, father had back pain late onset. She was HLA-B27 negative. CRP was normal. MRI scan of the SI joints and spine was normal. The bone scan showed mild uptake at both SI joints. Physical exam showed generalized tenderness. The previous doctor put her on adalimumab, which is one of our biologics, and she had modest response. But really, she didn't have any other features of axial or peripheral spondylitis. And if you look at the new criteria, which are pretty generous criteria for making a diagnosis of axial spondylitis, you need to have, of course, age onset of under 45, back pain for more than 3 months, so pretty easy. And you have to have sacroiliitis on imaging and one other feature, okay? Just one thing, good response to NSAIDs, for example, family history, for example, B27, high CRP. So pretty easy. Or you can have just the B27 and more than 2 other features. So she didn't have this. And remember the spectrum for pre-radiographic. So MRI typically is positive. She had a bone scan. Notice bone scan's not on here because bone scan is too non-specific. If you go for run a marathon, you're going to have an uptake in your bone scan in your SI joints. And then, of course, later stages are back radiographic sacroiliitis and then syndesmophytes. Anyway, so previously maybe she was here, but no, she didn't have that active sacroiliitis. And speaking about the enthesitis, the peripheral spondyloarthritis classification, you need arthritis or enthesitis or dactylitis, so one of those, plus one of these, like B27 or IBD or psoriasis, or two of the remaining dactylitis or arthritis, inflammatory back pain in the past, positive family history. So if we stretch it, does she have inflammatory back pain? And inflammatory back pain is something we always ask about, and I notice the residents always ask about morning stiffness for inflammatory back pain. And in fact, it's not a very helpful question on history for backs, because here are the best 5 questions for inflammatory back pain. Did it start when you were 40 or under? Did it start gradually? Does it improve with exercise? Do you find there's no improvement when you rest? And do you suffer from back pain at night, which improves on getting up? Okay, so these questions, 4 out of 5 of them being positive, is our best way to diagnose inflammatory back pain. Because if you take people with inflammatory and non-inflammatory back pain and ask them these questions, here's what happens. So dark gray is inflammatory, like Engspond, and light gray is just the rest of us with back pain. And about half of us with regular back pain, it started under 40. Almost all of us is more than 3 months. Insidious onset, yes. Less than half. Almost half morning stiffness, right? It's a terrible question to ask. I think just stop asking for inflammatory back pain. You could still ask for rheumatoid arthritis, okay? So remember, it's not that I said don't ask it. Don't ask it for inflammatory back pain. Improvement with exercise, both do. And no improvement with rest, almost 50% of the regular old back pain. Alternating buttock pain is pretty good differentiator, but it's not very sensitive. And then pain at night doesn't work either. So isn't that interesting? These questions that we ask, which sometimes we hang our hat on that in morning stiffness, it's not a very good question. Anyway, for her, I was not able to confirm the diagnosis of spondylitis. I didn't think she had it. She didn't satisfy the criteria. What should I do at this point? What would you do? She's coming to me for a second opinion on Humira. What do you think? Stop the Humira. So what do I tell her? I'm meeting her for the first time. Yeah. You know, Sheila Au was with me on Tuesday, and I don't know, whichever students were with me, and I commented on this after the patient left. A previous dermatologist suggested certain treatments, and Sheila made a different diagnosis. But what she said was, when she said, stop that stuff, and she said, I could see why you were started on this stuff, but you know what? It's not working, etc. There's new information. Let's try stopping it. I think that's a nice way to do it. And I could see why, but I just didn't think with the help of time, I don't think this person has a spondyloarthropathy. Kaylor said, let your colleague know of your opinion, return patient to his or her care. Let's face it, he or she may agree, or he or she may point out the gasp, I'm wrong, and produce some info which I'm not being aware. And that's true, but I don't think I'm wrong here. I don't think so. And the other thing is, here's the problem. If I return the patient back to the other doc and say, you know what, I think that 3 years ago you made this diagnosis, you put this patient on this drug, and et cetera, et cetera. I think that we're all human. We will have these biases. And I think the big bias that we make is called anchoring bias. I've given a talk here on metacognition and cognitive biases, but holding on to that first diagnosis with dear life because you made it and it's your baby, right? And it's hard to give that up. So I worry that people will anchor too much. And again, going back to the ethics, I think it's okay if, based on what the patient wants, that's the number one thing. And if it's not unreasonable, then I think we should just go ahead and do it. I'm happy to take over. Okay, next case. Feel free to interrupt. I know you have a patient at at 12:30. The next case, John Snow, 26-year-old man with reactive arthritis. And I think we know where he got it from, right? So he likely developed it in his reactive arthritis in his right ankle, left forefoot after a chlamydia infection. He has mild psoriasis and a history of plantar fasciitis. He's had iritis ×3, seen by rheum several times, symptoms persisted, NSAIDs trialed, sulfasalazine offered, but he wanted a second opinion before starting on a 6-month course of something. So I agreed with the treatment. He agreed I'd send a copy to his previous room, and he requested follow-up with the previous person who was closer, and he was happy. This is perfect. You know, it's a quick answer. Go ahead and start that sulfasalazine, and instead of, you know, what's something that I might have suggested methotrexate. Long-term antibiotic therapy has not shown to be a benefit in reactive arthritis, though the study's been done. So you think, well, is it persistent infection? But anyway, so that was perfect. Nothing to do there. How about this guy? This was a 25-year-old MMA fighter with recurrent leg rash and fever. Okay? He was an Iranian background. He works as a bouncer in a club. He's had this previously twice. He's also had recurrent abdominal pain requiring emerge visits here, and he's seen rheumatology in the past for recurrent ankle swelling, but did not want to return. No obvious diagnosis. What's going on with this guy? What do you guys think? Remember, he's got recurrent leg rash, fever, abdominal pain, went away by itself, recurrent joint swelling, and this was the rash on his ankle. Iranian background. FMF, what's FMF? You guys know? Familial Mediterranean fever. Dr. Palaco, I think you're correct. He has familial Mediterranean fever. Yeah. Recurrent abdominal pain, recurrent arthritis, you know, since a young age, erysipelas-like rash on the legs, and we've sent a couple to emerge here. The thing about the rash, it's kind of interesting, is that it's patchy. Like it's been often it's treated as cellulitis, but it's kind of patchy, and it doesn't progress like cellulitis, but it's super painful. Anyway, the diagnosis sometimes takes a while to declare itself, I explained to them. It's a difficult diagnosis to make because you come in with disparate symptoms of abdomen, joints, skin at different times. And we confirmed it by genetic testing. And in retrospect, they're like, you know, my mom, my sister, so they're all coming in and we're diagnosing. Ended up not showing up for follow-up appointments, this guy. And what he wanted another opinion, Barry said. But, you know, so what can people with FMF die of? Do you guys know? Long term? If you're not treated? Amyloid, yeah. So that's the thing. It's so easy to treat with colchicine, and certain subtypes are highly likely to develop amyloidosis and die of it, because there's really, once you get it, proteinuria, heart failure, there's no going back. So we need to try to find this guy and make sure he's getting appropriate treatment. Perhaps a few more. Elena Tyrell, a 75-year-old woman with polymyalgia rheumatica. Her daughter happened to be my patient. Daughter has RA, doing really well on triple therapy. Mom, on the other hand, not doing too well due to steroid side effects and chronic polymyalgia rheumatica, despite adding methotrexate. My go-to for PMR, by the way, is add methotrexate early on. I think it's a steroid-sparing drug. It's not always agreed to with by my colleagues. Ken, what do you think? Do you like methotrexate? Ken's waffling on it. I don't know. Anyway, referred to me at the daughter's insistence, you got to see my guy. He did really well for my rheumatoid. Anyway, I said I agreed with this. I add methotrexate, sure. But now mom thinks her initial rheumatologist is annoyed at the second opinion, doesn't want her back. I didn't have much to add, and now she's driving 2 hours to see me. But she's with her daughter, so it's okay. Kayla says, see my previous comments. You, kind sir, have been manipulated. That's okay. It's still all right. Okay, next case. Brienne Tarth, a 35-year-old with rheumatoid arthritis. She's on methotrexate, 25 sub-Q weekly for new RA, but not responding yet. It's a bit early. NSAIDs were tried. She's rheumatoid factor positive, anti-CCP positive. CRP is elevated at 35 and very low functional level. I got a RACE call. I really like the RACE line, by the way. It's really great for primary care physicians that get into us. Who participates in RACE? Yeah, great. I call us racists, right? We're all racist. Well, it's a good acronym. Anyway, the RACE line is great. The RACE called to me because the rheumatologist she was flaring, and he wasn't able to see her for 4 weeks and doesn't respond to calls and now is away for 2 weeks. I said, okay, I'll see her in the meantime. We'll fix it up. I emailed the room, promptly responded, and he was apologetic, said that sorry, it was a slip up. Someone else in the office should have called her back. But she was annoyed and didn't want to return because of the lack of responsiveness.
Code gray, code blue button. Please dial 7111 for all code blue. Code gray, code blue button. Please dial 7111 for all code blue. Code gray, code blue button. Please dial 7111 for all code blue.
So she didn't want to go back because of lack of responsiveness. I started triple therapy. I'm sure she's going to do fine. But, that didn't have to happen. Once again, errors occurred. Attending room was apologetic, would likely have apologized to patient had he or she had a chance. Probably. But I think the damage was done in this case, and she's just like, I don't want to go back. Joffrey, 22-year-old with psoriatic arthritis. Joffrey and his mother, and remember who his mother was, right? Anyway, Joffrey and his mother wanted a second opinion regarding his psoriatic arthritis. He was on methotrexate and partially responsive. Here's what happened. When we agreed to see him, the GP, I said, oh, my secretary said, well, send the previous notes and stuff. And the GP said, I'll send the imaging and the labs, but I won't send the notes because that's going to influence you in your opinion. So, and the family, when I saw them, said, well, we didn't want you to know what the other doctor said because it will change your mind. And that got me to thinking, does the first opinion alter the second opinion? And Kaler said, I would find this insulting and would reconsider offering the second opinion. He must have been very cranky at the day he was sending me this note. How do you know that info given initially would be withheld or vice versa? Anyway, I'm like, okay, I thought this was intriguing, so I'm like, sure, let's do it. But it got to, that was her mom, and my question was, do first opinions alter the second opinion? And I looked at a few studies on this, and apparently, yes for ortho, not for neurology. And I guess we're more like neurology, perhaps. Anyway, 72 orthopedic surgeons, 160 neurologists were given 8 scenarios. One group was told what another physician suggested, and the other group did not. And then they came to see what the answer was. The orthopods were more interventional when the other surgeons suggested intervention, but neurologists didn't change opinion. And knowing neurologists as we do, you know what? They're not going to change their opinion, right? Based on something previously. And I think we're more like that. So Barry said, if the first opinion will affect your opinion, never do independent medical examinations. That's true. But I think you need to look at people fresh. It's nice to see the patient, but I don't think that having the previous opinion would make our change. What do you guys think? Yes? No? Yeah, sometimes. So maybe they were right in asking me to see this person fresh without reading the other guy's note. Anyway, I was okay with that.
Did you get it after?
I don't remember if I got it after here, but it was clearly psoriatic arthritis, and I made the recommendations. Yeah, it was kind of interesting little test. And this is another one with patient-requested second opinions. That interestingly, there was a major change in diagnosis, treatment, or prognosis in this systematic review, and up 10 to 60%, depending on the study. So I thought that was kind of interesting. That, there was some change. So when someone's requesting a second opinion, things aren't going so well, maybe the diagnosis, treatment, or prognosis is not correct. Yeah, and Kaler said you could agree to do it if the original room will get a copy and you're not taking over care immediately providing a second opinion. That's reasonable too, but As I'm getting older, I'm getting more relaxed about, yeah, sure, whatever. It seems to work better for me than being too rigid. What do you think?
We are rigid.
But as you get older, you're less rigid in terms of, you're like, yeah, I don't know. He wouldn't know because he's not old yet. But remember cognitive biases here. I think that the premature, these are the three biggest cognitive biases I think we do. Premature closure, and that's an old guy thing to do. It's like, oh, I've seen this 100 times, this is going to be this. And you don't go that last couple of steps to confirm. Anchoring bias, holding on to that first diagnosis or the one you've really committed to. And availability, focusing on stuff you're familiar with. So if you send someone to a neurologist, you're going to get neurology diagnoses. If you send someone to me, you're going to get rheumatology diagnoses. So I think, because that's what I'm familiar with. So if you send someone with a headache to me, I'm thinking giant cell arteritis, even though frequency of giant cell arteritis as a cause of headaches is super low if you take all the headaches out there. So my conclusions are that most patient-initiated second opinions are driven by a difficulty with communication, in my experience, rather than by a clinical question. And these are the majority that I've seen. The physician-initiated second opinions are driven more by clinical questions. And I think the second opinion is helpful in both cases. In particular, if the patient's not following good advice because of communication issues. So usually it's the communication that's the cause of the problem. And the second opinion, I think, may be altered by the first opinion, but there's not a lot of good evidence for this. So given that communication is an issue, these are the rules that I give my residents in regards to communication. I remind them to smile, shake hands, introduce self and others, sit down, don't stand. I remember once I was standing with a bunch of trainees over the bedside of a patient lying down, and she had Berger's disease, and she was losing her fingertips, and she was smoking, and I was kind of getting on her about smoking and the Berger's disease. And she sort of pointed at us and said, all of you people have your own addictions, I'm sure. And I was thinking, this is really a bad physical situation with her. And, the next time we came in, we tried to sit down. But anyway, sit down, listen, and pay attention to body language. I think these are really the simple rules that if you can be really a very average physician, you do this, just the easy stuff. You're going to be way more effective. I think don't rush the patient, jump to conclusions, minimize their complaints, and definitely don't disparage them or other healthcare practitioners. Sometimes we see this, and it's bad all the way around. So it's all about the communication, and I think we're going to stop there, Barry, and hear what you guys have to say. Jake.
So I want to talk about this other opinions influencing your opinion. So those of you who know me know that I take a probabilistic approach to differential diagnosis. So if I say I think this guy has GCA and a 75% chance this is GCA, I will then use that as my template for more information, and I will revise it up or down. If I tell Barry the story, and Barry says, I don't think this is GCA, my 75%, if I respect his opinion, my 75% might be lower, just as if I had a negative test, or a consultant or something like that. So I do believe that, or if the patient comes to me with a diagnosis of GCA and I don't think it's GCA, then I'm not going to put a 10% on my opinion, I'll put a 20% on my opinion. So I think that every piece of information you have, including what someone else thinks, should feature into your probabilistic approach to your differential diagnosis.
I like that. I like that, and I often ask the residents, "What's your pre-test probability here of a diagnosis if you're going to get a biopsy, for example, and other things?" No, I do like that. Or I get them to commit. I think you should and you're basically getting yourself to commit to a number. I like that.
And I'll change my mind based
Yeah.
on, or not change my mind, but I'll alter my probabilities based on what my residents
Yeah,
think.
and further information that comes through. Any comments on that? Why are you laughing at Jake, Barry?
Well, the only comment I would make is that I try not to look at any information before I see it first.
Okay.
So I have the information, but I never read it. So I go in and just listen to the story and try to think of it myself without looking. But I have that information after I've considered what I think's happened. So it's just a difference.
That's a nice way to do it. Jane, what do you do? Jane, do you do, which way do you do? Do you read the stuff before? I'm just picking on you.
And so, for instance, I will not look out when the house staff presents a case to me in emergency. I will not look at the lab results so that I can formulate my opinion and my probabilities based on the history and physical work that I have. And then those lab results have much more
Meaning.
statistical rigor because I don't know them in priority. So if I've already made a hypothesis and I look at the lab and it confirms my hypothesis, it has much more statistical rigor than if I've been told it before and didn't generate it before. And so I'm trying to get everything is like this is the parallel stream I'm trying to get everybody to do, and everything is the way we've always done it, but also there's a mathematical, statistical, formal rigor that you apply in parallel. So I can't do that if I know lab stuff before I presented the case. So in some respects, I have like a radio silence, information blackout. Other times I want to know what I need to know better.
Jane, what do you think?
It's funny. I don't have a large patient practice, so I'm not asked to do the same opinion, but I take various steps in terms of I don't want to know. I want to know your opinion.
Okay. Yeah, back.
I think with Dr. Cass, really got it for the complex, like the big practice for unbiased. And then there's a second thing that I saw a lot of where the diagnosis is clear, but they're very specific clinical questions. I think for both, but especially this, when you the case of the first, like even if you don't look at it beforehand or let it be tactical, that's the diagnostic process. There's often a big disconnect between what the patient has heard or understood from the doctors or what the doctor thought the diagnosis was or what they were proposing. That is comforting. So it's hard to actually address this question.
But I think eventually you do read.
Oh yeah, no, I do, but I don't read it at the outset.
At the outset.
Before.
There and there.
So it's always, when I'm hearing it that way, I'm hearing it, I'll always come back to the case. There's just the patient. Try to remove the other part of this.
So in a paper world, when we're moving out of that, that type of history that's repeated and look at the chart and the chart gets thicker and thicker and thicker. We used to call that congestive chart failure.
Jake.
Sorry, I think if you look at how our system works now, we have a triage attending an emergency who admits the patient, renders an opinion, sets in motion a plan. The next day, oftentimes, there's a different staff physician that takes over. That staff physician, I would consider, is often offering a second opinion. They have more information, but it's just a built into the system second opinion. And we can't go in there blind, and we never get any work done. So we rely heavily on the opinions of the person, and in fact, we insist on getting them before we go see the patient.
Yeah.
Because we get handover before communication. So I would suggest that if you want to take that, you can't go in blind on a daily basis, case after case.
No, I think it's the complicated, like seeing multiple docs and yeah.
They're not asking, but they're building the system.
Yeah.
I don't know if you've married them. I think that I think it's really worth not to but so I think it's also not by your hope that you wanted to this expectation of wanting to do it, your knowledge is not is that then you can leave it as you feel.
Mhm.
I think it's important to render your opinion and then you have to let it go.
Anita, what do you think? Yeah. I have to admit, I would like to do your way, but what happens is usually the resident goes in, and I might go onto Care Connect at the same time and download a bunch of stuff because we don't have it, right? So I can't help but not look at it. But so I do glance at it, but I try to just keep my I try to go through the tried and true way. The history is so important. 80%. Physical exam, 15%. And it's true, even to this day, with all the amazing labs and imaging we have, the investigations, 5% of the information, the important information that makes our diagnosis. The history is so good. That's why when by the end of the history, if you don't know have a good idea what's going on, you're kind of in trouble. Anita, how do you do it?
So I think we do rely a bit more in that breakdown on physical exam, on other information, on lab tests.
And the history comes from the previous notes and the history where the patient doesn't remember or can't tell you.
The next day, you might be able to verify aspects of history the person is communicating. The case complexity is very high. So I think the residents probably react like that.
It's a good point.
I also think because of how we train, we have a tendency to, it's when I see your patients, I look at everything on Care Connect, read every consult, and then I get their story. So it's such a different, but I know, like I've watched you do your thing, and I'm like, it's very interesting. I've never done that way.
But I guess just to add to that, I mean, when you're rushed, oftentimes you're going to try to compress information, and then you look at the information in the emerge and you see these labs. I'm trying not to do that because even then, it's biasing you, and if you're going in, and sometimes your history is just validating some of the things you think you've seen, without actually really understanding the problem. Mm-hmm. So I find it's true that time is a big pressure, but if we had all the time in the world, I still think the best thing to do is not know anything and just seek to listen to the problem. But sometimes we're scratching and no one's itching.
Mm-hmm.
I think the bottom line is you need to know the strengths and weaknesses of your own approach. You need to be vigilant that you're not falling into any of those diagnostic traps. So if you do it with the information beforehand, you have to be aware that you may be prejudiced. If you do it cold, you have to be aware that you're evaluating some stuff without the common knowledge approach that you should have to evaluate. So, you know, so if you go in and take a history and you get, and it's an anemic patient with black stools who just vomit blood and they want to tell you about their stomach ache from 10 years ago or in great detail, you can get led astray. But if you already know that their hemoglobin is 65,
Yeah.
So context is really important, and I think it's important to know your strengths, your weaknesses, and all the potential pitfalls, and just be vigilant, ever eternally vigilant, because you're making mistakes all the time.
I totally agree with you, and and to do that, I think we have to remind ourselves about the different types of biases. Just FYI, and just a couple of them. Ascertainment, like when judging a disease more likely if it readily comes to mind. That's so when I missed a epidural abscess like 15 years ago. That year, everything I looked at, could this be an epidural abscess? If it was coming to mind, and available. The opposite too. If you haven't seen something ever or rarely, it's not going to come to mind. And then the other one, the biggest one, by the way, is an emerge as feedback sanction, and that's when the emerge doc will make a diagnosis. This is GCA. Here's your steroids. Goodbye, and doesn't get the feedback afterwards that wasn't, these last 10 cases were not GCA, right? So we get feedback when we see people as an outpatient that because there's no immediate consequence to the emerge doc. They don't actually see that. And the other one that we have as physicians is commission bias, which is we like to do more than we like to wait and watch. So action rather than action. But anyway, I think Jake is right. Remember to look up the biases, and I can send you a good paper from a Canadian physician on the types of cognitive biases we have. That's the best way to know yourself.
But part of this is doing the history and principle of what we're talking about, and part of it's a second opinion, which is what you were talking about.
Yeah.
Second opinions, I think, aren't seeing patients in emergency. Second opinions are being able to take the time.
Yeah.
And you're making the time to take the time. How you approach it, I guess, is your individual way. But that's how I look at it.
And the other thing about second opinion, you know you're giving one, so you're actually taking, like Barry Kaler said to me, you know you're doing it, you know there was some communication issue, so you're taking extra time to go through things, just to catch these where the mistakes or potentially missed things were done.
But Anita is correct, that we're not giving second opinions often in emergency.
Yeah.
We're giving half of it, a quarter of it.
Yeah.
We're filling in maybe 3/4 of the puzzle.
Yeah.
Yeah.
It's putting together this puzzle. Yeah, we might, sometimes it's just the border.
Survival opinions.
All right.
We're alive until the morning.
Yeah.
So you actually probably thought your talk was completed, but we're going to make you stand here for the full hour.
Thank you.
Thank you very much.
Thank you.
Thanks, Tom.
Thank you.
Always good.
Thank you.
Very
It's fun.
patient.
Yeah, I know.
Any other staff need yes? I want to go ask Alex.
I want to go to my kids' art fair. No, I want to see a couple of people before.
Okay. I want to ask Alex.
No, it's like a crash. Yeah, she's selling T-shirts. She made it herself. I don't know.
I feel like this time
Iron Dawn is. the dog lying on all the t-shirts.
Oh, okay.
I didn't know I had all these
They
things.
have you like okay.
I have to ignore half the messages. You can read half of them.
Yeah.
Okay. You can just go see. You could just clarify that.
Oh, don't worry about the back.
Begging for support. They're not begging. It's freezing. Yeah.
Oh, okay.
What are you using? What for you? You're done.
Well, yeah.
Whatever you do,
And set trash.
Yes, I was like super
I wanted to do that. They said,
Yeah, that's fine. Well, I have the forms. They wrote in the next note, like, please change the let's refund if you get stuff asking for
not staff.
That's correct. And the
No episode. Yeah, that was what I said.
yeah, it's been a lot of time.
No, I actually wanted. But they seem to think set drives as a
Synergy.
instead of
Yes.
too sensitive end, but
So yes,
I don't understand myself.
No, I brought food so
Oh, right. Yeah.
That's interesting the one that you saw with the walk.
Yeah.
Your call will be disconnected.